Okay, let's unpack this. Welcome to the Deep Dive, where we take a stack of your sources and extract the most important nuggets of knowledge to help you master complex topics like an elite professional. Today, we're embarking on a crucial journey into the heart's less often discussed but incredibly vital structures, primarily the tricuspid valve, but also laying a foundational look at the mitral valve, as our source material from Chapter 266 guides us. Our mission is to truly understand the why behind the what in these often complex conditions.
It's remarkable how interconnected the cardiovascular system is, isn't it? While our core focus today is indeed tricuspid valve disease, the Insights Chapter 266 provides also offer a crucial window into mitral valve prolapse. This holistic view is absolutely essential for a true understanding. We're going to synthesize complex diagnostics, explore nuanced pathologies, and dissect cutting-edge treatments to give you an unparalleled grasp of these conditions. This isn't just about knowing the facts. It's about seeing the entire intricate system at play and understanding why specific details truly matter in clinical practice.
You've brought us some incredibly rich material, and we're going to ensure you walk away not just informed, but genuinely insightful, ready to connect the dots. Get ready for those moments where complex pieces suddenly click into place. What immediately struck me as particularly insightful in Chapter 266, even though it's titled Tricuspid Valve Disease, is how it starts by drawing our attention to mitral valve prolapse. Why is this condition on the left side of the heart so foundational to understanding what we'll later discuss on the right? What exactly is this phenomenon?
That's a critical observation. Understanding MVP isn't just an arbitrary starting point. It's foundational because it introduces us to core principles of valve mechanics, imaging, and regurgitation that apply across all valve diseases. At its heart, MVP is a condition where the mitral valve leaflets, those crucial flaps separating the left atrium from the left ventricle, don't close perfectly during the heart's contraction phase, known as systole. Our source defines it with striking precision. Systolic displacement of the belly of the mitral valve leaflets by at least 2 millimeters into the left atrium, LA, superior to the plane of the mitral annulus.
2 millimeters. That sounds quite specific.
It is. Think of it like a parachute. Instead of the mitral valve's leaflets closing neatly and tautly, they billow upwards, ballooning into the left atrium. Figure 265-2 in the source beautifully illustrates this, showing Barlow's valve with classic mitral valve prolapse and its myxomatous leaflets billowing into the left atrium in late systole. This billowing motion caused by excessive or abnormal leaflet tissue means they don't meet properly, which can allow blood to leak backward. It can involve one or both leaflets, creating a spectrum of severity. This billowing parachute analogy perfectly captures the anatomical problem.
Okay, so if it's this kind of abnormal motion, how do elite clinicians actually pinpoint MVP? What's the diagnostic process like, moving from, so subtle suspicion to a confirmed diagnosis?
That's a crucial question for any clinician. Pinpointing MVP isn't about one single test. It's more like a multimodal detective story, layering different diagnostic tools to build a complete picture.
So where do you start?
Well, first, let's consider the electrocardiogram, or ECG. The crucial insight about ECG in MVP is its deceptive normalcy. The ECG is frequently normal, which can be misleading if you're not attuned to the subtle hints. However, it can sometimes offer specific, albeit less common, indicators like biphasic or inverted T waves in leads 2, 3, and AVF. Interestingly, you might also see supraventricular or ventricular premature beats, which are extra heartbeats originating from above or within the ventricles, hinting at some electrical irritability. So while not definitive on its own, it's often a piece of the puzzle suggesting electrical anomalies rather than providing the whole anatomical picture of the valve itself. An expert knows not to rely on ECG alone for MVP diagnosis, but to integrate it into the larger clinical context.
Which is one clue. So what's the main diagnostic tool then?
The true diagnostic powerhouse, and arguably the cornerstone of MVP diagnosis, is echocardiography. This includes both transthoracic echocardiography, TTE, and transesophageal echocardiography. TTE is particularly effective in identifying the abnormal position and prolapse of the mitral valve leaflets because it gives us a real-time moving image of the heart's structures. We use specialized techniques like color flow and continuous wave Doppler imaging to evaluate the associated MR, that's mitral regurgitation, or the backflow of blood into the left atrium and provide estimates of severity.
And how accurate is that severity estimate?
Well, what's particularly insightful for a clinician here is that the regurgitant jet, the stream of blood flowing backward, is most often eccentric. This means it doesn't flow straight back, but kind of off to the side, which can make assessment of the effective regurgitant orifice area and regurgitant volume difficult with standard techniques from a TTE. This eccentricity is a crucial detail that informs the choice of further imaging or even surgical planning, as it makes accurate measurement challenging and demands advanced techniques.
So if TTE has limitations due to that eccentric jet, what are the next steps for getting more precise information?
Good question. For more precision, especially when we need detailed assessments of the heart's pumping chambers, both three-dimensional echocardiography and cardiac magnetic resonance imaging can provide more precise determinations of LV volumes. These advanced imaging techniques give us volumetric data, helping to quantify the impact of the regurgitation on the heart's left ventricle. And when more accurate anatomic information is required, particularly for surgical planning, transesophageal echocardiography, TEE, is indicated and is performed routinely for intraoperative guidance during valve repair.
TE, that's the one where the probe goes down the esophagus.
Exactly. Imagine a tiny ultrasound probe being passed down the esophagus, placing it directly behind the heart. This gives surgeons an incredibly clear, real-time view of the mitral valve from that vantage point, which is invaluable during a delicate repair procedure, almost like having a direct line of sight.
Okay, so we have ECG, TTE, maybe 3D echo or CMR, and TE for surgical planning. What about how the patient actually feels or functions?
Right, that's vital too. To understand how MVP impacts a patient's functional capacity in their daily life, exercise testing can be performed when there is uncertainty regarding functional capacity. This isn't just a simple treadmill test, it's often combined with rest and immediate post-stress TTE to assess LV and right ventricular RV function and the dynamic nature of MR and pulmonary artery pressures. It's about seeing the problem under physiological stress, as symptoms might only appear or worsen with exertion. This helps us understand how the heart truly performs when pushed, and while left ventriculography, which involves injecting dye into the left ventricle during a cardiac cath, is rarely necessary, it can also show prolapse of the posterior and sometimes of both mitral valve leaflets if performed. So it's this comprehensive, layered approach that ensures nothing is missed, allowing for a precise diagnosis and effective management.
Once MVP is confirmed, what's the expert approach to treatment? It sounds like it's far from a one-size-fits-all situation, especially given that range of diagnostic findings you just described.
Indeed, treatment decisions are highly individualized, hinging on the severity of the mitral regurgitation, the presence and nature of symptoms, and the overall health of the heart function. This is where the art of medicine truly meets the science.
So what are the options? Medical management first.
Yes, for medical management, the focus is often on symptom control and prevention of complications. For patients with a prior history of endocarditis, that's an infection of the heart valve, infective endocarditis prophylaxis is indicated. This is a preventative measure, often involving antibiotics, to protect the heart valve from future infections. Symptoms like chest pain and palpitations, which can be quite distressing for patients, can often be relieved with beta blockers. These medications help slow the heart rate and reduce the force of contraction, easing the heart's workload.
And what if they have AFib too? Atrial fibrillation.
Good point. If a patient with MVP also has atrial fibrillation, AF, an irregular and often rapid heart rate that can lead to blood clots. Decisions regarding anticoagulation for stroke prevention in AF should be based on the CHA2DS2 VOSC score and an assessment of bleeding risk. The CHA2DS2 VOSC score is a quick way clinicians assess a patient's risk of stroke, factoring in things like age, diabetes, and heart failure, helping them decide if blood thinners are necessary. It's about balancing the risk of stroke with the risk of bleeding,
Makes sense. So when does surgery come into play?
Now, let's talk about surgical intervention, specifically mitral valve repair. This is the gold standard and is indicated if the patient is symptomatic from severe MR or if there are findings of established or progressive LV systolic dysfunction. In other words, if the backflow of blood is significant enough to cause symptoms or start damaging the left ventricle's ability to pump effectively, surgery becomes a strong consideration.
What about patients without symptoms?
That's a more nuanced indication. For low-risk, asymptomatic patients in whom a successful and durable repair can be achieved with at least 95% likelihood by an expert surgeon, this highlights a crucial proactive approach. Even without symptoms, if the valve can be reliably fixed by a highly skilled surgeon with a high probability of success, it might be beneficial to intervene early to prevent future problems and preserve heart function.
And repair is better than replacement.
Generally, yes. It's crucial that mitral valve repair is preferred over replacement in patients with MVP or flail mitral leaflet because it preserves the native valve structure and function, which generally leads to better long-term outcomes for the patient, avoiding things like lifelong anticoagulation or repeat valve replacements. However, the technical success is dependent not only on the anatomic findings but also on the skill and experience of the surgeon. It's not always straightforward.
How so?
Well, repairing isolated posterior leaflet prolapse is usually straightforward, but increasingly more complex pathologies, e.g. anterior leaflet prolapse, bileaflet prolapse, Barlow's deformity, require advanced skills. This complexity underscores why careful pre- and intraoperative T imaging is an important component of patient evaluation and surgical planning, giving the surgical team the best possible roadmap during a delicate, real-time procedure.
Okay, so repairs preferred, but complex. What about less invasive options? Are there any for MVP?
Yes, absolutely. The cutting edge of treatment involves transcatheter options. For patients at high surgical risk with severe primary MR due to MVP, meaning they are not good candidates for traditional open heart surgery, a less invasive option exists. Transcatheter edge-to-edge repair, TEAR, using a clip to grasp the anterior and posterior leaflets together. This innovative procedure, often referred to as a MitraClip procedure, effectively creates a double orifice, reducing the leak.
Does it completely fix the leak?
Not always. While it will be reduced in severity but not eliminated, meaning it won't completely stop the leak in many cases, TEAR can still improve symptom status and indices of LV size and function. This approach has become much more accessible, now offered at 475 specialized sites in the United States, with reported hospital mortality rates following the procedure are 2%, which is a remarkably low figure for a cardiac intervention, especially in these high-risk patients. It's important to note, though, that other transcatheter repair and replacement devices are not yet approved for clinical use in the United States. So TEAR is currently the primary transcatheter option in this specific context. This constant innovation is what keeps the field moving forward.
Having now explored the intricacies of the mitral valve on the left side, let's swing our attention to its often overlooked counterpart on the right, the tricuspid valve. We'll start with tricuspid stenosis. This seems to be a lesser-known cousin to mitral stenosis, which is much more commonly discussed. What sets it apart right from the outset, and why is it so rarely seen?
That's an excellent point about its rarity. Indeed, tricuspid stenosis, or TS, is much less prevalent than mitral stenosis, MS, in North America and Western Europe. This rarity means it often goes unrecognized or is considered later in the diagnostic process, making it a true diagnostic challenge for many. When it does occur, it's generally rheumatic in origin, meaning it's usually a long-term complication of rheumatic fever, and it's more common in women than men.
Rheumatic origin like mitral stenosis often is.
Exactly. Now, here's a crucial insight for an elite professional. TS does not occur as an isolated lesion. This is absolutely key. You almost never find TS by itself. Instead, it is usually associated with MS mitral stenosis. In fact, the source notes that hemodynamically significant TS occurs in 5–10% of patients with severe MS, highlighting its strong link to left-sided heart disease. Furthermore, rheumatic TS is commonly associated with some degree of tricuspid regurgitation, so you're often dealing with two problems at once on the tricuspid valve, both narrowing and leaking. Non-rheumatic causes are rare, which helps narrow the focus significantly. This interconnectedness with MS is why, for an expert, the presence of one should always prompt a careful search for the other.
Given that close relationship with mitral stenosis, what exactly is happening inside the heart when someone has tricuspid stenosis? How does this bottleneck affect the blood flow in the rest of the body? Paint us a vivid picture of the deep physiological consequences.
Let's delve into the deep physiological consequences of this bottleneck, because they directly inform the clinical picture. TS is hemodynamically defined by a diastolic pressure gradient between the right atrium, RA, and right ventricle, RV. This means there's an abnormal pressure difference during the heart's filling phase, diastole, as blood struggles to move from the RA through the narrowed tricuspid valve into the RV. Imagine trying to pour water through a pinched hose. The pressure builds up behind the pinch.
And that gradient changes.
Yes, this gradient actually is augmented when the transvalvular blood flow increases during inspiration and declines during expiration, a critical diagnostic clue that we'll touch on later. When you breathe in, more blood rushes to the right side of the heart, increasing the flow across the valve and making the obstruction more apparent, which is very helpful for diagnosis during a physical exam or echocardiogram.
Even a small gradient matters, right?
Absolutely. Even a mean diastolic pressure gradient of 4 mmHg, which might sound small, is usually sufficient to elevate the mean RA pressure to levels that result in systemic venous congestion. Okay. This is incredibly significant for the patient. When the right atrium struggles to empty, blood backs up, not into the lungs, like with left-sided heart problems, but into the systemic venous circulation. It's like a plumbing system backing up into the entire house. The result is fluid backing up into the body's major veins and organs, leading to a cascade of symptoms. The source notes this venous congestion is associated with hepatomegaly, an enlarged liver, ascites, fluid in the abdomen, and edema, swelling, particularly in the legs, sometimes severe unless managed with sodium intake restriction and diuretics.
So major fluid overload symptoms.
Exactly. And in patients with normal sinus rhythm, the RAA wave, which is the little bump on the jugular venous pulse tracing reflecting the right atrium contracting, may be extremely tall and may even approach the level of the RV systolic pressure. This towering A wave is a direct measurable sign of the high pressure the RA is generating. Conversely, the Y descent, which reflects the rapid emptying of the right atrium, is prolonged. This prolonged descent signifies that blood is slowly, laboriously flowing through the narrowed valve.
What about overall heart function, cardiac output?
Well, the cardiac output, or CO, at rest is usually depressed and it fails to rise during exercise. This low CO means the body isn't getting enough oxygenated blood, leading to symptoms like profound fatigue. Furthermore, and this is a key insight for expert diagnosis, this low cardiac output can actually mask the hemodynamic and clinical features of any associated MS by keeping left atrial, LA, pulmonary artery, PA, and RV systolic pressures normal or only slightly elevated. So, the tricuspid stenosis, by reducing overall blood flow through the heart, can deceptively make the mitral stenosis appear less severe, leading clinicians to potentially underestimate the full extent of the valvular disease. This masking effect is a critical nuance.
That paints a very clear picture of the internal struggle. So how does all that pathophysiology translate to what a patient experiences and what a clinician observes? What are the telltale signs of TS that would lead a truly professional clinician to consider this rare diagnosis?
The clinical presentation provides crucial insights, especially since TS is often a coexisting condition and its symptoms can be, well, deceptive.
How so in terms of symptoms?
In terms of patient experience and symptoms, since MS often develops before TS, patients might initially present with symptoms of pulmonary congestion and fatigue related to their mitral valve issue. However, what's truly characteristic for severe TS is that patients complain of relatively little dyspnea for the degree of hepatomegaly, ascites, and edema that they have. End quote. This is a critical distinction. Unlike mitral stenosis, where lung symptoms like shortness of breath dominate, here the fluid backup in the body is disproportionately severe compared to their breathing difficulties. Instead, fatigue secondary to a low CO and discomfort due to refractory edema, ascites, and marked hepatomegaly are common in patients with advanced TS and/or TR. So the primary complaints shift from shortness of breath to issues of profound fluid retention and debilitating low energy. Sometimes TS is only suspected for the first time when symptoms of right-sided failure persist, even after successful treatment of existing MS, indicating that an additional problem on the right side is definitely at play.
Okay, so less shortness of breath, more systemic fluid overload and fatigue. What about the physical exam?
Now, for the physical exam, this is where the expert eye truly shines, because TS usually occurs in the presence of other obvious valvular disease, meaning it may be missed unless it is considered. This underscores the need for a high index of suspicion. Severe TS leads to marked hepatic congestion, often resulting in cirrhosis, jaundice, serious malnutrition, anasarca, that's generalized massive swelling, and ascites. So a severely enlarged, tender liver, yellowing skin, muscle wasting, significant fluid. You'll also see congestive hepatomegaly, and in cases of severe tricuspid valve disease, splenomegaly, so both liver and spleen can be enlarged. The jugular veins in the neck are characteristically distended, reflecting the high pressure in the right atrium. And with sinus rhythm, there may be giant O waves in the jugular venous pulse, unusually large pulsations corresponding to that forceful RA contraction against the stenosis. The V waves are less conspicuous, and due to obstruction, there's a slow A descent, signifying that slow emptying. In sinus rhythm, you might even feel prominent presystolic pulsations of the enlarged liver as it pulsates with the atrial contraction.
Wow, the liver pulsating.
Yeah.
What about listening to the heart? Auscultation.
When we move to auscultation, an opening snap, OS, of the tricuspid valve may rarely be heard 0.06s after pulmonic valve closure. This is a crisp, high-pitched sound. The diastolic murmur of TS has many of the qualities of the diastolic murmur of MS, and because TS almost always occurs in the presence of MS, it may be missed. Again, that diagnostic challenge. However, the key to identifying it is its location and dynamic changes. It's generally heard best along the left lower sternal border and over the xiphoid process, and most prominent during presystole in patients with sinus rhythm. But the most crucial distinguishing feature, the definitive sign, is that the murmur of TS is augmented during inspiration, and it is reduced during expiration, and particularly during the strain phase of the Valsalva maneuver.
That's Corvello's sign, right?
Exactly. That's the classic Corvello sign for TS. It's because inspiration increases blood flow to the right side of the heart, making the murmur of obstruction louder, a beautiful demonstration of physiology at the bedside.
Fantastic clue. What about other tests like ECG or X-ray?
Yes, lab and imaging clues provide objective evidence. The ECG often shows RA enlargement with tall peaked P waves in lid 2, as well as prominent upright P waves in lid V1, classic signs of an overloaded right atrium. A critical diagnostic hint is the absence of ECG evidence of RV hypertrophy, RVH, in a patient with right-sided heart failure who's believed to have MS should suggest associated tricuspid valve disease. If the RV isn't getting bigger, the problem might be upstream at the valve. The chest X-ray reveals particular prominence of the RA in superior vena cava, without much enlargement of the PA, and with less evidence of pulmonary vascular congestion than occurs in patients with isolated MS. Engorgement of the nzygos vein can often be appreciated. On TTE, the tricuspid valve is usually thickened and domes in diastole, physically showing the stenosis. The transvalvular gradient can be estimated by continuous wave Doppler echocardiography, giving us that pressure difference. For an elite professional, severe TS is specifically characterized by a valve area 1 centimeter 2 or pressure half time of 190 meters. These specific cutoffs are critical for quantifying severity. TTE also confirms the RA and inferior vena cava IVC are enlarged and provides additional information regarding the severity of any associated TR, mitral valve structure and function, LV and RV size and function, and PA pressure. It truly is the workhorse.
With such complex manifestations and the potential for masking other issues, what's the treatment strategy for tricuspid stenosis? It sounds like there's a lot of careful preparation involved before any intervention.
Treatment requires careful consideration, often preparing the patient extensively before surgical intervention, which is usually the definitive step.
What kind of preparation?
Let's begin with preoperative preparation. Patients with TS generally exhibit marked systemic venous congestion. They're severely fluid overloaded. Therefore, salt restriction, bed rest, and diuretic therapy are required during the preoperative period. This strict regimen aims to reduce the fluid, alleviating the burden on their overloaded right heart. This preparatory phase is vital because it may diminish hepatic congestion and thereby improve hepatic function sufficiently so that the risks of operation, particularly bleeding, are diminished. A severely congested liver is less functional, impacting clotting, so improving its health before surgery is crucial.
Okay, prep first, then surgery.
When it comes to surgical solutions, timing and approach are key. Surgical relief of TS should be carried out preferably at the time of surgical mitral commissurotomy or mitral valve replacement, MVR, for mitral valve disease. This highlights the strong association. Since most have both TS and MS, it's usually best to address both in one operation. Surgery is indicated for moderate or severe TS who have mean diastolic pressure gradients exceeding 4 mmHg and tricuspid orifice areas 1.5 to 2 cm 2. Those are the objective criteria. Since TS is almost always accompanied by significant TR or regurgitation, operative repair may permit substantial improvement of tricuspid valve function. Repair is always preferred if possible.
But if repair isn't possible,
then the tricuspid valve may have to be replaced. Interestingly, meta-analysis has shown no difference in overall survival between mechanical and tissue valve replacement for the tricuspid position. But a key point for long-term management is that mechanical valves in the tricuspid position are more prone to thromboembolic complications than in other positions, like aortic or mitral. This means a higher risk of blood clots forming on the valve, necessitating more aggressive long-term anticoagulation therapy, a critical factor in decision-making.
and what about less invasive options here, like the balloon procedure?
Regarding newer frontiers, percutaneous tricuspid balloon commissurotomy for isolated severe TS without significant TR is very rarely performed. This is primarily because, as we discussed, isolated severe TS itself is exceedingly rare, making the need for this specific procedure infrequent. While percutaneous approaches are getting ground elsewhere, surgery remains the mainstay for TS currently.
Now, let's pivot to the most frequently encountered tricuspid valve problem, tricuspid regurgitation. Given that we just talked about how rare tricuspid stenosis is, why is TR so much more prevalent, and what makes it such a significant challenge to manage, often even more so than TS?
That's a critical distinction. The vast majority of TR cases, more than 85% of TR cases encountered in clinical practice, are secondary, functional in nature. This is the fundamental reason for its prevalence. Unlike primary valve disease, where the valve itself is inherently abnormal, secondary TR means the valve's function is impaired because of problems elsewhere in the heart or lungs. It's often a consequence of other cardiovascular issues. It's intimately related to tricuspid annular dilation and leaflet tethering in the setting of RV remodeling caused by pressure or volume overload, or both, myocardial infarction, MI, or trauma. Essentially, the right ventricle gets stretched or damaged, pulling the valve leaflets apart or hindering their closure.
So secondary TR is the main driver. Can you break down the causes a bit more?
Absolutely. Let's look at primary versus secondary TR. Secondary TR is very commonly seen in the late stages of heart failure due to rheumatic or congenital heart disease with severe PA hypertension, PA systolic pressure 55 millimilli Hg. High lung pressures overload the RV, causing dilation. It's also prevalent in other types of left-sided valvular, for example, mitral regurgitation or myocardial diseases, area G ischemic and idiopathic dilated cardiomyopathies. Problems on the left often lead to problems on the right. Even chronic RV apical pacing and desynchronous contraction from pacemakers can cause it, with lead sometimes interfering with the leaflets. Furthermore, new-onset atrial fibrillation, AF, can also lead to atrial functional TR, particularly in older patients, as the irregular atrial function affects valve closure. So secondary TR stems from many common conditions.
And primary TR, where the valve itself is the problem.
Primary TR is far less common. Causes include rheumatic fever, often with TS. Others are tricuspid valve prolapse, carcinoid heart disease, endomyocardial fibrosis, radiation, infective endocarditis, especially IV drug use, and leaflet trauma. Less commonly, it can result from congenitally deformed tricuspid valves, like defects of the atrioventricular canal, as well as with Ebstein's malformation, a specific congenital defect. The sheer number of conditions causing secondary TR is why it's so much more common. It's often a symptom of wider cardiovascular stress.
That distinction between primary and secondary TR is crucial. So when the tricuspid valve allows blood to flow backward, what are the cascading effects on the heart and circulation? Paint us a picture of this backflow and its physiological consequences.
The pathophysiology is critical, and it's definitely like watching a complex system under stress. Fundamentally, the incompetent tricuspid valve allows blood to flow backward from the RV into the RA during systole, the volume of which is dependent on the driving pressure, i.e. RV systolic pressure, and the size of the regurgitant orifice. Higher pressure, bigger leak, more backflow. Imagine pumping water with a leaky piston.
And this varies a lot.
Yes, the severity and signs are incredibly dynamic, varying with PA systolic pressure, the tricuspid valve annulus dimension, how stretched the ring is, respiratory cycle-dependent changes in RV preload, and RA compliance. During inspiration, for example, RV filling is increased, which can transiently worsen the regurgitation and make its murmur louder, that key diagnostic clue again. Crucially, in significant TR, forward CO is reduced and does not augment with exercise. The heart struggles to pump enough blood forward, especially during activity, causing fatigue and exercise intolerance.
What does that backflow do to the heart chambers?
Significant TR leads to RA enlargement and elevation of the RA and jugular venous pressures, with prominent CV waves in the pulse tracings. The RA enlarges to handle the extra volume, raising pressure. The CV waves in the jugular pulse are characteristic, showing the surge of backflow during RV contraction. With progressively severe TR, you can even see ventricularization of the RA waveform, where the RA pressure tracing starts to look like a ventricles due to massive overload. This constant volume overload causes RV dilation and eventual systolic dysfunction, impairing its pumping ability. This decline can be accelerated by a concomitant pressure load from PA hypertension or by myocardial fibrosis. So the backflow leads to progressive RV failure, impacting the whole circulation as blood backs up into the liver, gut, and tissues. It's a relentless cycle.
That makes the underlying mechanisms of TR very clear. So how does this manifest in the patient's symptoms, and what exactly can clinicians observe during an exam that would point to significant TR, distinguishing it from other conditions?
The patient's experience and physical findings are absolutely crucial, especially since TR can often hide behind other conditions.
What symptoms should we look for?
In terms of symptoms, mild or moderate degrees of TR are usually well tolerated in the absence of other hemodynamic disturbances, so people might not even know they have it. However, since TR most often coexists with left-sided valve lesions, LV dysfunction, and/or PA hypertension, symptoms related to these may dominate the clinical picture. Shortness of breath from MR might overshadow TR symptoms initially. Early TR symptoms typically include fatigue and exertional dyspnea owing to reduced forward CO. As it progresses, though, the signs of right-sided fluid overload become prominent. RUQ abdominal fullness, bloating, diminished appetite, and muscle wasting, although with progressive weight gain and painful swelling of the lower extremities. This is due to blood backing up into the liver, gut, and legs.
So again, fatigue and systemic fluid issues rather than primarily lung symptoms. What about the physical exam findings?
Now, for the physical findings, these are often more telling than the symptoms, especially for severe TR. The neck veins are distended with prominent CV waves and rapid Y descents in the absence of TS. These pulsations are a direct visual sign of the backflow. What's fascinating here, and a critical teaching point, is that TR is more often diagnosed by examination of the neck veins than by auscultation of the heart sounds, emphasizes the importance of looking at the neck veins. Other signs include marked hepatomegaly with systolic pulsations, the liver is enlarged and pulsates ascites, pleural effusions, edema, and a positive hepatojugular reflex sign where pressing on the liver makes the neck veins swell more. You might also feel a prominent RV pulsation in the left parasternal region, indicating an enlarged or hyperactive RV.
And listening, the murmur.
On auscultation, there's a characteristic blowing hollow systolic murmur along the lower left sternal margin, heard throughout contraction. This murmur is classically intensified during inspiration, Carvalho's sign, and reduced during expiration or the strain phase of the Valsalva maneuver. This inspiratory augmentation is the absolute key to distinguishing it from mitral regurgitation, which does not intensify with inspiration. That Carvalho's sign again, but this time for regurgitation. Also, it's noted that AF is usually present in the chronic phase of the disease, adding another layer.
That's incredibly detailed. So what are the essential laboratory and imaging tests needed to fully understand TR and its impact, allowing for precise diagnosis and tailored treatment?
The expert approach relies on a comprehensive combination of tests to fully assess the severity and consequences of TR, connecting the clinical signs with the internal physiology.
What about basic labs and ECG?
First, laboratory examination can offer indirect clues. The ECG may show changes characteristic of the lesion responsible for the TR, like signs of a prior RV heart attack, inferior Q wave MI, RVH, right ventricular hypertrophy, or even specific patterns seen in Ebstein's anomaly. In sinus rhythm, ECG signs of RA enlargement may be present, and as we noted, AF is frequently noted. The chest X-ray may show RA and RV enlargement depending on the chronicity as a starting point.
And then echo, presumably.
Absolutely. The cornerstone is transthoracic echocardiography, TTE, and advanced imaging. TTE is central, revealing RV dilation and RV volume overload. It also shows the valve leaflets. Prolapsing, flail, scarred, or displaced tethered tricuspid leaflets with annular dilatation, providing anatomical detail. The diagnosis and assessment of TR severity are made definitively by color flow Doppler imaging, visualizing that backward jet of blood. A specific telltale sign of severe TR is hepatic vein systolic flow reversal, blood flowing backward into the liver during contraction, a clear indicator of severe pressure backup. Continuous wave Doppler of the TR velocity profile is useful in estimating PA systolic pressure, crucial for assessing pulmonary hypertension, except when the TR is very severe and the jet velocity is blunted.
Why is assessment challenging sometimes?
Well, what's challenging here is that accurate assessment of TR severity, PA pressures, and RV size and systolic function with PTE can be quite challenging in many patients due to the complex 3D geometry of the right heart and the jet itself. For more precision, real-time three-dimensional echocardiography and cardiac magnetic resonance (CMR) imaging provide alternative imaging modalities, offering superior volumetric and functional assessments, though they are not widely available everywhere.
What about direct pressure measurements or exercise testing?
Yes, hemodynamic and functional assessment provides critical physiological data, often via cardiac catheterization. In severe TR, the CO is usually markedly reduced, explaining the fatigue. The RA pressure pulse may not exhibit an X descent, but rather show a prominent CV wave with a rapid Y descent, perfectly matching the neck vein findings. Also, the mean RA and RV end diastolic pressures are often elevated, reflecting the volume overload. For asymptomatic patients, exercise testing can be used to assess functional capacity. However, the prognostic significance of exercise-induced changes in TR severity and RV function has not been well studied, so its role in predicting outcomes needs more research.
That's a truly comprehensive set of diagnostic tools. Finally, let's talk treatment. How do elite professionals manage tricuspid regurgitation? From medical options to the latest interventions, especially given its complexity and frequent association with other heart conditions. It seems like a constantly evolving landscape.
The management of TR, as summarized in the guidelines referenced in Figure 266-1, is indeed multifaceted, requiring a tailored approach balancing symptom relief, treating underlying causes, and considering invasive options.
Let's start with medications.
Okay, medical management aims to support the heart and alleviate symptoms. For patients with severe TR and signs of right heart failure, meaning significant fluid overload, diuretics can be useful to help shed excess fluid. An aldosterone antagonist may be particularly useful for managing hepatic congestion, specifically targeting liver fluid retention. Crucially, it's also vital to address underlying causes. Therapies to reduce elevated PA pressures and/or pulmonary vascular resistance, including those targeted at left-sided heart disease, can also be considered for patients with PA hypertension and severe secondary TR. This is a core tenet. You must treat the root cause, like high lung pressure or left-sided valve issues, as fixing the primary problem can often improve the secondary TR.
And when is surgery indicated?
Next, surgical intervention. Tricuspid valve surgery is recommended for patients with severe TR who are undergoing left-sided valve surgery, a Class I recommendation. Fix it while you're already there, essentially. It's also undertaken frequently for treatment of even moderate TR in patients undergoing left-sided valve surgery who have tricuspid annular dilation, specific measurements given, a history of right heart failure, or PA hypertension. So even moderate PR gets fixed proactively in these situations to prevent progression.
Again, repair over replacement.
Yes, when possible. Operation most often comprises repair rather than replacement, as preserving the native valve is preferred. This has become routine in most major surgical centers. For severe primary TR that doesn't respond to medical therapy or has progressively declining RV systolic function, isolated surgery may also be infrequently required. However, it's important to know that reported perioperative mortality rates for isolated tricuspid valve surgery are high, 8 to 9%, and likely are influenced by the hazards encountered during reoperation on patients who have undergone previous left-sided valve surgery and have reduced RV function. Standalone TR surgery is riskier, often in sicker patients. Furthermore, indwelling pacemaker or defibrillator leads can also pose technical challenges during surgery.
And the future, transcatheter options again.
Lastly, the future of TR treatment is exciting with transcatheter innovations. As with mitral disease, investigation of transcatheter tricuspid valve repair and replacement systems is ongoing, promising less invasive options for high-risk patients. These are still largely evolving but hold great promise. And just to be complete, for surgical planning, preoperative coronary angiography should be performed routinely based on risk factors to check for coronary disease. And cardiac catheterization and angiography may also be helpful when there is a discrepancy between clinical and non-invasive findings to get direct measurements if needed. #outro.
So what does this all mean for you as someone aiming for that elite professional understanding? We've gone from the intricacies of mitral valve prolapse, recognizing its foundational role in treatments, to the nuanced challenges of tricuspid stenosis, its rarity, systemic impacts, and link to MS. And finally, a deep dive into the more common yet complex tricuspid regurgitation, dissecting its causes, especially secondary TR, understanding its effects, and exploring the treatment landscape from meds to surgery and emerging options. You now have a truly comprehensive understanding of the diagnostic tools, the subtle symptoms, and the intricate treatment strategies, equipped to consider the why behind the what in a way that truly connects the dots.
Indeed. This exploration should really highlight how these specific valvular conditions, often seemingly isolated, provide a powerful window into the broader systemic health of a patient. Consider how changes in one valve, say the tricuspid, can ripple through the entire cardiovascular system, influencing outcomes and even masking other issues like TS obscuring MS. The ability to identify these interconnected effects, understand their nuances, and anticipate their consequences, that's what truly defines an expert. It's moving beyond single pathologies to the complex, dynamic interplay within the whole system.
So the next time you hear about a heart murmur, perhaps you'll think beyond just a heart problem and consider the intricate ballet of pressures, volumes, and leaflet movements, from a tiny 2 millimeter mitral prolapse to a giant A wave in the neck veins. You'll appreciate how low cardiac output can mask other conditions and how advancements like transcatheter repairs are continually redefining what's possible for patients with these complex conditions. It's about seeing the whole story.
Absolutely. And as you continue your own learning journey, remember that mastering a field isn't just about knowing the facts, it's about building that intuitive connection between the physical exam, the detailed imaging, and the patient's lived experience. It's about understanding the relationships, the nuances, and the why behind the what. That's the real aha moment, and it's what truly elevates knowledge to expertise.